Welcome, welcome everybody. I anticipate a few more people will continue to log on in the next couple of minutes, and that today's live participation might be a little bit lower, it being the tail end of summer, everyone trying to get away. But this session is being recorded and it will be posted and shared after the event. So I'm going to go ahead and dive right in and introduce us to this event because we have a very exciting evening or afternoon, I guess, if you're in BC, which many of you are. We have a very exciting hour ahead of us. There we go. So welcome to Cross-Pollinations, the Canadian Association for Health Humanities Virtual Round Series. I'm Nick Brewer. I'm from the League of Canadian Poets. We are a partner of this series. And we have here as well Sarah DeLeo, who is the past president of the League of Canadian Poets and either the incoming or current president of the Canadian Association for Health Humanities. I'm not sure. So thank you for joining us today, Sarah. And this series is, sorry. I'm so sorry. I had a long day and I had a nap before this event, and apparently I'm not fully awake yet. I would like to begin with a land acknowledgement. The League of Canadian Poets is situated in Toronto. Wherever you are, you may be well versed in this already, but I would encourage you to find out what territories you're situated upon, and perhaps some of the grassroots organizing that's happening in your area by Indigenous land defenders and Indigenous activists. In Toronto, the territories that we are situated upon are the traditional homes of the Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the New Credit First Nations. This particular bundle of land is collectively referred to, the treaty that was assigned for this land was the Toronto Purchase, and it applies to lands east of Browns Line to Woodbine Avenue north towards Newmarket. We recognize the enduring presence of Indigenous people on this land, and we also recognize that art, poetry, and poetic practice related to the work of an organization that takes place in traditional territories of many different nations. We encourage you all to learn more today about the lands where you live and work. If you care to share any links, knowledge, or information in the chat, I encourage you to do so, and I will scroll through that. We are also, forgive me, I work for the League of Canadian Poets, and I don't entirely understand all of the medical side of these things, but we have been certified for MainPro accreditation, and this slide has been provided to me, so I'm just going to read it to you. Each presenter has been given instructions about the conflict of interest form prior to their proposed session date. Included in this package are instructions on how to mitigate bias in their presentations. For example, if there's any reference to specific medications in their presentations, to use generic names. Through this process, we endeavor to prevent any perceived or real conflicts of interest. However, if any conflicts of interest become apparent during the session, please alert the session host, me, via the Zoom chat, and we will intervene. I am also going to provide a link in the chat where you can provide feedback on this session after it is complete. And that's through a form, and that's very helpful to us in many ways. I'm going to go ahead and stop sharing my screen now. And I have spotlighted all four of our presenters here today. So if you are in gallery view, hopefully they should be front and center for you. And I'm just going to introduce them with the information that they sent me ahead of time and not talk that much longer. We have our poet today is Conyer Clayton, and Conyer is going to read for about 10 or 15 minutes following our presentation towards the end of the hour. Conyer is a writer, musician, editor, and gymnastics coach living on unceded Algonquin and Anishinaabe territory. Her debut full-length collection, We Shed Our Skin Like Dynamite, was a finalist for the 2021 Relit Award. She won the Capilano Review's Robin Blazer Poetry Prize and ARC Poetry Magazine's Diana Brebner Prize. She has released 2 albums and 8 chapbooks, most recently Sprawl, The Time It Took Us to Forget, from Collusion Books, written with Manahil Koala, whose name I did not practice saying out loud, and Towers, also from Collusion Books, by Roman numeral 7, of which she is a member. Nancy Dwan is a first-year internal medicine resident in Vancouver at UBC. She is an artist who was formerly trained in the visual arts before deciding to pursue medicine, but art will forever be her first passion. She has been intimately involved in the arts and humanities community in medicine at UBC and has organized art shows, performing arts events, and coordinated and participated in narrative medicine workshops for healthcare. She believes exploration of the arts and humanities in medicine builds resilience in healthcare providers and allows for more empathetic and compassionate care for patients. Zamana Mitani is a second-year medical student at UBC. Before medical school, she completed her Master's of Bioethics at Harvard Medical School, where her love for narrative ethics melded with her love for poetry, comedy, and our ways of understanding our identities in the world. She believes that narrative medicine can be a tool patients and providers can use to work through medical dilemmas, and has given workshops on Sufi poetry and bioethics to physicians and ethicists at the American Bioethics and Humanities Conference. Her work can be found in ethics and psychiatry academic journals and in her family WhatsApp groups. Karen Wang is a first-year psychiatry resident training in Winnipeg, Treaty 1 territory. During medical school, she was involved with Frames of Mind, an initiative in Vancouver utilizing film and the arts to spark conversations about mental illness, centering the voices of people with lived experience. Her love of literature and medical humanities brought her to the practice of narrative medicine. And I'm very, very excited to learn all about narrative medicine. And I am going to let you guys take it away now. Thank you so much for being here.
Thank you so much for that introduction, Nick. So I think I'm going to start sharing our slides. Just give me 1 second. Let's see. There we go. You guys can all see the presentation slides right now.
Yes, thank you.
Okay. So I'll let Zamina start for us.
Perfect. So hello, everyone. We're going to be talking today about narrative medicine and its role within medicine and medical education. So the next slide. It's just our little disclaimer that we have absolutely no disclosures. And so next. And thank you so much, Nick, for that fantastic introduction. Zamina, Nancy, and Karen, and of course, Conyer. And so we're going to run through, next slide, please, the agenda for today. So we're going to introduce a little bit on what narrative medicine is. And we have 3 parts to the presentation today. So the first one is understanding patient narratives. The second is understanding physician narratives. And the third is putting together 1 and 2 and talking about how we can collectively share these experiences together and create connections between the 2 worlds. And in that, we have Kanyer's amazing set. And we hope to end this session with something really interactive, which is a prompt that we have, which will tie in Kanyer's poetry and what we discussed today. And hopefully we can have a little bit of sharing, or if we don't, you have something to come and take back with you after the session.
Wonderful. So the first question we should probably start with is, what is narrative medicine? And we'll go on to the next slide. This is a term coined by Rita Sharon of Columbia University. Rita Sharon writes that the effective practice of medicine requires narrative competence, the competence used to acknowledge, absorb, interpret, respond to, and act on the stories and plights of others. She recognizes that it's not just our scientific knowledge or academic competence that helps patients navigate their illness journeys, navigate their losses and suffering, and finding meaning in these experiences. She says that along with scientific ability, physicians need the ability to listen to the narratives of the patient, grasp and honor their meanings, and be moved to act on the patient's behalf. This acknowledges the bidirectionality of the clinician-patient relationship, recognizing the patient as an expert in their own story and acknowledging the humility needed to hold these stories. Next slide. So what does this look like? Our narrative medicine workshops are composed of a close reading section and then a reflective writing practice. The close reading is an exercise of attention. We do a close reading or viewing of a text, image, video, really anything. And it's like the way that you watch a movie multiple times and you see something new in the movie each time you watch it. When we look at a painting, we see first the big image and then later on the smaller strokes and parts, the foreground, the background. When we hear a story, we hear first the words that are spoken. Narrative medicine trains us to pay attention to the different parts of these stories. How many characters are there? Who is telling the story? What is the emotion in the scene? What is said? What is not said? In psychiatry, this is what we call a mental status examination, the observation of what the patient's telling you, as well as what they show you. In our reflective writing portion, we provide a space for our participants to respond and reflect on their own experiences, using the text or art piece as a springboard. Oftentimes we find that the stories that we're grappling with are at the forefront of our minds. So we place the emphasis really on writing down what we're thinking of in the moment, using a short time limit rather than allowing participants to revise and overthink the way that we write our stories.
Okay, so the next parts that we want to go into are really those 3 sections that we broke down narrative medicine into. And it's really about the different ways that we feel narrative medicine has really contributed to our medical education or our medical practice as trainees. And the first part that I wanted to get into was how narrative medicine helps us, recognize and hold these patient narratives, because we're interacting with patients every single day who are often going through, a lot of challenges in their lives. And it's good for us to be able to recognize that and to be also able to, see our patients as people. So as Nick had introduced, I am an internal medicine resident, and I think we're very well known for how we break down our patients into this issue list. So like I've written here, in the hands of the physician, a patient becomes a list of issues. I've just started writing out this generic list of issues for a patient I very often see in the hospital. They might be coming in with what we call congestive heart failure exacerbation with a very low left ventricular ejection fraction. And then they might also have a concurrent acute kidney injury with also type 2 diabetes, some electrolyte abnormalities, and maybe some other chronic medical conditions that we also need to keep in mind and address while they're in hospital. And of course, this kind of practice we're very encouraged to do from the beginning of our training, and it really helps us address the patient's needs in a systematic way. And I think that it's really useful for how we take care of patients. But on the other hand, sometimes I do think that if we're not careful, the patient just becomes a list of issues, and we forget to look at the patient as a whole person when we're kind of rounding out their care. And that really includes thinking about the patient's personal barriers to healthcare and taking care of themselves, and what their goals and their wishes are with regards to their own medical care. So an example that I wanted to give was my personal experience in the ICU. So this is how the ICU generally looks. Patients are intubated, which means that they have a breathing tube connected to a machine that helps them breathe. This also means that they're sedated. They're generally not awake. They can't talk to you. They can't tell you how they're feeling, or if anything's bothering them, or what their current wishes and concerns are. Everything that I learn about the patient in the mornings comes from all the numbers that I see on their monitors, that I see on their lab work, the pictures that I see when I send off for imaging and we get those imaging results back. So in this kind of situation, I found it incredibly easy to dissociate the patient and their issue list from them being actual people. And I remember looking back, I spent a month in the ICU, and I remember looking back on that month and realizing how many patients I saw pass away in the ICU, because generally it's quite a high number. And I realized that I hadn't even taken the time to process all of those deaths, and that I felt a lot of moral distress and emotional distress from not having processed those deaths until the very end of my rotation. And so how can narrative medicine really help us explore patient narratives? I really believe that narrative medicine allows us to exercise or practice exercising empathy for our patients by experiencing patient narratives, or just the narratives of anyone with illness, through art forms. And these art forms can include anything from poetry, prose, literature, visual art, music, film, anything that you prefer. And we have an example here from a poet that Karen and I think Zamina too, we all really admire. Her name is Ada Limon, and she actually suffers from scoliosis, which causes her chronic back pain. This is an excerpt from one of her poems titled Wonder Woman, and I'm just going to read this short excerpt to you guys. So she writes, standing at the swell of the muddy Mississippi, after the urgent care doctor had just said, well, sometimes shit happens. Pain pills swirling in the purse along with a spell for later. It's taken a while for me to admit I am in a raging battle with my body, a spinal column 35 degrees bent, vertigo that comes and goes like a DC Comics villain nobody can kill. Invisible pain is both a blessing and a curse. You always look so happy, said a stranger once as I shifted to my good side grinning. So I think reading these types of, narratives from people with illness allows us kind of a glimpse into how we can be more empathetic towards the patients that we take care of. I actually thought of this poem immediately one day when I was just talking with one of our patients who we recently gave a diagnosis of multiple myeloma to, which is a type of blood cancer. And she was complaining to me about how no one had come in to check up on her in a long time. And she told me, just because I look okay doesn't mean that I am okay on the inside. And as soon as she said that, I thought about this poem, because a lot of our patients do look well on the outside, but on the inside, they have illness and they are suffering. So in these ways, I think these narratives that we read and these art forms that we read allow us to exercise a lot of empathy.
Here we have another example of examining patient representations and identity. Frida Kahlo is also a woman who struggled with chronic pain. She's an artist who's known for her unique self-portraits. In her painting, Tree of Hope Remains Strong, we see two representations of her, contrasting the ill self with the well self. We see her as an injured woman on a gurney, and as someone in a regal gown looking straight at the viewer. She's holding her back brace as if to say she is the one in control, not the brace. This is the same way we see patients differently when they're in a hospital gown on a stretcher versus when they're in the clinic wearing the clothes that they choose for themselves. Through juxtaposing the Ada Limon poem and Frida Kahlo's self-portrait, we can explore the ways that people's illness experiences are seen and not seen.
So Karen and Nancy have really talked about two really beautiful examples of patient narratives, the poem and of course this painting, and of course tying in their own experiences as residents currently. And I think I'm going to explore that a little bit with some additional literature. So if we can go to the next slide. So I know a lot of people have read the book When Breath Becomes Air, written by Paul Kalanithi, and he is a phenomenal writer. So this is a really interesting excerpt because it's actually on a physician in training. It's describing this phenomenon of going into the anatomy lab, which is something that medical students or healthcare providers in training often do. Basically, it's a cadaver lab. And so, the person has passed away and you're going and examining different parts of their body. And Paul writes, in the anatomy lab, we objectified the dead, literally reducing them to organs, tissues, nerves, muscles. By the time you'd skinned the limbs, sliced through inconvenient muscles, pulled out the lungs, cut open the heart, and removed a lobe of the liver, it was hard to recognize this pile of tissue as human. Anatomy lab in the end becomes less a violation of the sacred and more something that interferes with happy hour, and that realization discomfits. In our rare reflective moments, we were all silently apologizing to our cadavers, not because we sensed the transgression, but because we did not. This excerpt for me, I think, highlights what Nancy discussed earlier, which is one of the dominant physician narratives, especially as you go through training, and it starts in training, is this big narrative of depersonalization and disassociation from things like the anatomy lab to the issue list that Nancy discussed. And I remember my first anatomy lab in person was jarring for me because I was used to seeing dead bodies in a very different way. So I participate in a postmortem care and sort of rituals as part of like my Islamic community. And so I was very used to seeing dead bodies, but I had seen them, washed them, cared for them, and, you know, prepared them for burial in a way that was done by seeing their face. Whereas in anatomy lab, they covered the face in order to depersonalize the person. I saw their families, I saw the names of these people. We buried them with things that were special to them and rubbed objects or scents on them that were really holy and sacred to them or important to them and their families. We knew how they passed away. We, you know, saw the people that were close to them in that very intimate environment of someone being dead and being passed on, but how that, you know, is not only them as an individual, but how they are connected to an entire life world and life story of family and community. And so for me, seeing a cadaver in an anatomy lab, totally like, you know, as Paul describes here, you know, lobe of liver here, the trachea there, it was very jarring and juxtaposing to how I had previously seen dead bodies before entering med school. And I think for me, it answers one, or it brings up one particular question, which is at the heart of narrative medicine, which is like the difference between the body of someone that we often look at with medical issues and their selves, their stories. And we have to ask ourselves, is the body truly separate from the self? And I think the answer narrative medicine gives is that when we, you know, look at a person not just as their anatomical features, but as their entire life story, their memories, their hopes and dreams, we really look at them as a whole self. And so the next slide. And I think looking at this person as their whole selves can really be a tool to understand this idea of moral distress, which is something that physicians and healthcare providers often face in their field. And so moral distress, one definition, this is actually from the CMA, is that it occurs when one feels unable to take what they believe to be ethically appropriate or the right course of action in their patient care. So for example, like, you know, avoiding wrongdoing or harm because of either institutional obstacles or internalized or internal obstacles. So this can include anything from, you know, the law, the structural fabric of the hospital or the clinic itself. And internal obstacles can be even things like power dynamics between, you know, physicians and residents and training, medical students, nurses, PAs, everyone in the whole allied healthcare system. And even things of, you know, dissonance between, you know, your personal beliefs and, you know, what you're required to do medically can also be an internal obstacle, creating feelings like moral distress. And I know Karen and Nancy have already discussed those beautifully in their own examples and their own stories. And so what's the relationship between moral distress and narrative medicine, and how can we bring this as a tool? I think in our view, it's a bilateral relationship. So writing, drawing, singing, theater, all of those things in the arts in general can be things that physicians can use to process their own moral distress when they see a particularly difficult situation, or even in the everyday nuances of what it means to care and heal and be in that very ardently responsible and powerful position. And it's to process, you know, for example, narrative medicine can be used as a tool of processing, to process, you know, the times that we don't have answers or platitudes like it's going to be okay, or you always look happy, as Adel Iman says. And so, you know, it can also be, though, in the reverse, narratives can be a tool that we can use to recall frameworks and stories to process the new ones that patients give us. And so the more stories we're exposed to, the more readily we're able to recognize the narrative arc in our own patients' lives. And we can recognize those moments as, you know, for example, in the ICU, intubated, as not that isolated anatomical moment, but maybe as the climax in their story. And in Greek tragedies, this particular concept is called peripetia, which is the sudden reversal of fortune within a tragedy. And it can often be that point in which a patient presents to us as well. And so both this, writing our own narratives and being able to read a patient's narratives can accomplish this goal of mitigating moral distress, and achieving the goal of empathy as a whole, so that we can resonate with another person's entire story and resonate with the patient's story and join them in their empathy and join them in the plot that they have created and the part that we have to play in that.
So sometimes medicine isn't always glamorous. It isn't always what we imagine it to be. We come in with this conception of physician identity, the healer, the listener, the holder of stories. And sometimes, as Zamina alluded to, we aren't really able to fulfill our ideas of this role. We might not be able to provide the treatment someone needs. We might discharge someone from the hospital to the street. Sometimes we just don't have the space to hold everyone's story. And compartmentalizing patients into a problem list is a way to avoid the emotional burnout and moral distress that comes with this role. I remember the first time I did CPR was on an emergency medicine rotation. And that day I responded to my first code blue, which is what happens when there's concern for someone's heart stopping or when they have difficulty breathing. And these codes go on until the patient is resuscitated or it's determined that they're beyond saving. So I walk in from the emergency department to a different hospital ward to a patient I had never met before. After many rounds of CPR, we stopped and the patient died. And right away, we went back to the emergency room, back to suturing minor cuts, seeing people with coughs as if nothing had happened that day. And as Paul Kalanithi suggested earlier, the biggest discomfort wasn't that I carried the grief with me, but it was that I didn't. Because prior to the code, I had never met the patient before. I had never met their families or even really known what their course of treatment in the hospital was like. And these feelings were really at odds of my idea of what being a clinician was, being someone who cared and could hold all of these stories. And I'll go on to the next slide. And I found these feelings reflected in a poem by Katie Miller. She is a therapist in St. Louis, and she wrote a poem called Death Visit Pentone. I'll read part of it to you because it's a long poem. She writes, "The mask I wear is a human mask when I do not know the dead one. A human mask is only my own face when I have known the dead one." She says, "I am the messenger of all faces. I am sorry for your loss. I am humble before your faces. Yes, he is dead. I am sorry for loss, having known or not the man." Her poem really points out these lines that we as clinicians are so trained to automatically spout out as markers of verbal empathy. I'm sorry for your loss. And these are words like platitudes that really don't acknowledge that when we see our patients, these are a very normal part of our days. They are probably some of the worst moments of our patients' lives. And in that room, we can share these platitudes, we can comfort their grief in that moment, but it's something that they still have to live with. I also noticed that she wrote, the dead one I must face, doesn't ask how I feel. It is a body in bed. It is the family who looks." And I find that oftentimes it's when I when I meet the family members of an ill person that I really begin to be reminded of this is a whole person with an identity before they were in hospital, before I've only seen them in their sick role as someone who is debilitated by their illness. And then at the end, Katie Miller writes, "I drive home, changing the face of sorrow. The mask I wear is a human mask." And again, we're able to really compartmentalize and put a barrier between our work self and our home self. At the end of the day, we still have the privilege of going home to our normal lives, to our normal families, and distance ourselves from everything that went on that day. And this is a necessary part of medicine, but it's also a difficult one to deal with. And narrative medicine can help us really acknowledge this dissonance. It may not help us fully resolve it, but to first process something, we have to at least name it and give words to it.
And the last part that I wanted to talk about in this creating physician narratives or healthcare provider narratives is that as an artist myself, I have found it to be very difficult to be creative in medicine. I find that there are a few spaces where there is a lot of creative self-expression. And that's why I really think that narrative medicine, as well as these other examples we've included, such as, visual arts activities like painting and drawing, online communities where we can share stories, and other book clubs and writing clubs, is why I feel that they're so important for, any sort of healthcare provider or anyone who often deals with these kinds of really emotionally difficult situations that we often see on our day-to-day. And this kind of creative self-expression allows for a reflection of your own experiences and your patient's experiences, and then it allows you to process them and then to, I would say, acknowledge them, and then maybe not necessarily resolve them, because sometimes the challenges that we face are very difficult to resolve, but it does allow us to kind of deal with them in very healthy ways. And the other part that I wanted to bring up, which ties into our third section, is that these kinds of creative self-expression activities, and narrative medicine in particular, are generally collective events, and they allow for collective sharing, and for sharing that makes you feel like you're part of a community. So narrative medicine, the way that it was built, the way that it was really, developed, which includes this close reading of a text and then this response to the text, it was meant to be a group activity. So it allows for catharsis and processing of distress and trauma through these interpersonal connections. And I really do believe that feeling like you're part of a community is so important for your own mental well-being. It not only allows us to understand our own experiences by learning from others and other people's experiences, but it also allows us to connect to others and help them construct their own narratives and help them understand their experiences. And I think in the end, it really kind of teaches you when you're learning and hearing about all these stories from other people, is that we're not alone in these often challenging and difficult experiences that we have. And these emotions and feelings that often, bring us a lot of distress. One of these examples I can give is we did a narrative medicine session once, and they're great. They're often filled with medical students, residents, practicing physicians, other healthcare providers. And I listened to the story from a seasoned family doctor, so he'd been practicing for many, many years. And he mentioned the frustration he had felt after a phone appointment with a patient when he heard the patient make disparaging comments towards him after the patient had forgotten to hang up the phone at the end of their appointment. And he expressed his frustration in some ways, his anger at that situation. And listening to it coming from such a seasoned physician, it really helped me feel like I wasn't alone sometimes in maybe negative feelings and the frustrations I may have during difficult patient interactions. And then it helps us break down those feelings when we share them with each other. And like I mentioned, to kind of process and then resolve them. So I really do believe that these narrative medicine sessions as group activities, as activities where we can practice creative self-expression, are incredibly healing for healthcare providers.
So in all, narrative medicine can have all of these three functions. It can help us build empathy for patients as people and not just their body parts and not just their medical diagnoses, their conditions, or their issue list. Number two, it really helps physicians themselves process moral distress and experiences into cohesive personal narratives. And again, like we've illustrated, this can be through storytelling with words, or it could be through art, or it could be through theater. And number three, this idea of sharing and receiving stories. This is a collective thing. This is a community process. It is one that involves connection And it is one that involves solidarity too, building within both physicians and patients and all healthcare professionals who engage in that kind of sharing of stories. And all in all, it contributes to building resilience in healthcare providers and trainees. And I really like this one quote by a medical sociologist, Arthur Frank, and he really describes narrative thinking. And he says that thinking with stories means joining with them, allowing one's own thoughts to adapt to the story's immanent logic and its narrative tensions so that you can feel its nuances and anticipate changes in plot. And that summarizes the kind of narrative thinking and competency that we build as physicians and in understanding patient narratives as we go through these 3 goals of what narrative medicine can do for us as a profession. All right, so we're going to transition now as a group and throw it in to Conyer and have her beautiful poetry. So it's all yours.
Thank you, Samina. Conyer, welcome back. And I wanted to just say quickly, I did receive a very gracious correction of Manahil's name, the poet's name in Conyer's bio that I mispronounced. Their first name, Manahil. I did not receive a correction on their last name, which I certainly did not say correctly because my brain couldn't process the letters properly. But Conyer, let's just dive right into your set. And at the end, I will stop recording and we will have a bit of an opportunity to ask questions and engage in a bit of a discussion. So thank you very much, Conyer. And thank you for that amazing discussion on narrative medicine. That was so interesting. Thank you.
Nick, actually, at the end of Konyer's set, we have a prompt that we were wondering if we could bring to the audience. And so we might actually have you reshare our slides after that, if that's okay.
Oh, wonderful. Sounds good.
All right. That was, so it's Manahil Bandu Koala is how you say her whole name. So that was amazing. Thank you so much, Karen and Nancy and Zamina and the League for inviting me here. I would have come and listened to that even if I wasn't reading. I feel really honored to be here. I'll say verbally, I have no conflicts of interest before I keep going. So I guess I'm going to start with, this feels very apropos to be reading. This is my first reading since starting some pretty intensive speech therapy after having a lot of vocal issues over the last year. And I wasn't even sure for a while if I would be able to do readings for a long time or continue my job coaching. So this feels just very apt, and yeah, I'm just really happy to be here. So I'm just going to talk about kind of what I've been going through over the last year. My patient journey over the last year was that as a gymnastics coach, I have to talk a lot and I have to talk very loud. And when we came back from the first COVID shutdown, I was coaching through a mask for the first time and had to project my voice a lot all the time. And I started having a lot of pain and fatigue and just chronic hoarseness and all kinds of symptoms like that. And I thought, like, oh, whatever, I had lost my voice a bunch in the past. This is whatever, it doesn't matter. I just kind of pushed through for a few months, tired every night, pain every night. I got a little headset, kept going, kept trying to do the thing. And then it hit a breaking point, probably February, March, where I started to be like, okay, something is going on. Probably should have clued in a little earlier. So I took, when we had the third lockdown, I was like, I'm going to take a week of no speaking and that should take care of it. So I did that and it did not take care of it. It didn't really help at all. So I started trying to get in to see my doctor, and he referred me to an ENT, but because of COVID and the lockdowns, I was told I wouldn't get seen until probably October or November. And at this point, I could barely speak for 2 or 3 minutes without starting to have pretty intense pain and feeling like I just always felt like I had something stuck in my throat. And I was starting to get really freaked out, but I couldn't really be seen by anyone. So I went through the full spring, really barely speaking, really limited for what I could do professionally, both in writing and in my job coaching. We were just doing Zoom at that point, but still. And just really anxious, really, really anxious, Googling my symptoms, which is a bad idea, and getting really freaked out. I finally got in to see someone in an hour drive outside of Ottawa in July, and it's not that big of a deal. I have some nodules, I have muscle tension dysphonia, I just need to do speech therapy and learn a completely new way to talk, which is what I'm doing right now. But it's been difficult, and part of the struggle is that it feels like I have a different personality now, almost, because I have a different voice. Because I've always been a loud person and I cannot be loud anymore. And I have to be pretty measured all the time. So anyway, that's my patient narrative. So I'm going to read 2 poems that relate to that at different points through that journey. So this first poem I'm going to read, I wrote in the spring when I had no idea what was going on. And I was just trying to talk myself out of a anxiety loop. This is called Diagnoses. I'm pretty sure I don't have gallstones, just GERD. The ultrasound confirmed it's just a ganglion cyst on my foot. I'm sure I don't have vocal polyps. I just need to do speech therapy. But I'm just guessing. The same way I'm guessing it's a groundhog who's shredding the petals of the tulips I keep finding on the porch stairs most mornings. I Google groundhog, the same way I Google growths. Groundhogs are the largest member of the ground squirrel family. Throat pain and chronic hoarseness are early signs of throat cancer, but it's usually something else. Groundhogs are generally a sign that your esophageal sphincter is irrevocably damaged. It could be from years of smoking weed and drinking and bulimia. It doesn't matter that I stopped years ago, that I finally quit burrowing. My paws have claws made to bury myself. That's how these things happen. I dig, and I don't question why. I notice a lump in my foot, and even when the doctor says, it's just a tulip, it's benign, I can always see it growing, yellow, and I think about plucking it every single morning. So this second poem is written just a couple weeks ago, and it's just about trying to feel like this is me when I speak. It's called Forward Resonance. I've been singing into a straw 2 to 3 times a day, like my speech therapist told me to, and humming and saying, ma, moo, me, my voice, my voice, my voice. This is my voice. This is my voice. This is my voice, until I sometimes believe it. I've made a new desire path, a quieter destination with a well-plotted program. They say moss chokes out the tension of seedlings, but I'm afraid asphalt will sprout instead, or I'll forget what the woods sounded like before I had to change them for the sake of their longevity. There was a cradling warble in the background, an ache in the neck of every new growth. I remind myself of kudzu now, though I know this voice is indigenous to the ecosystem of my larynx, had been hibernating and wait for my hyoid to drop down, the right conditions for it to flourish. The canopy opens to welcome a different light in. This tone is gentle, but I've never felt gentle before. I've clear-cut and blamed the stumps for not performing perfectly, despite the fact I felled them. I've written another poem now in which my forest is a body, but this is about the noise of me, lessened, letting wind blow between leaves and not tensing up against it. The wind will be as loud as the wind will be. That's fine. That's fine. Be quiet. Thank you, guys. This has been lovely.
Thank you, Conyer. I loved those poems so much. And I will throw it back to Zemina if you have a prompt.
Yes, we absolutely do. And I think Nancy, if you could reshare the slides again. We actually had the pleasure of hearing one of those poems from Kanyer's set, and we sort of chatted about, this idea of voice and what it means to lose your voice and find your voice. And that is sort of what we were talking about when we are trying to find each other's voices in our profession and our patient voices, and how we see patients, and Conyer just illustrating that beautifully with such stunning prose that you've heard today. And especially hearing you read it also brings another layer to the idea of voice. Ergo, our prompt right here. We would love if the audience would like to join us, of course, in any way that makes you feel comfortable. Poetry, prose, like do a little doodle in a sketchbook. If you have like clay or Play-Doh, I do, but I think that's a really weird thing to have at your desk. Anything that you have with you, write about a time or reflect about a time when you lost or found your voice.